Good day. I'm Dr. George Vetrovec, representing ACC.org and the interventional section. We're doing a discussion of results of some trials and really focusing on applicability of these trials to the practice of medicine and kind of what it means and what these trials mean to us. And we hope this will be very educational in a very functional sort of way. I have two excellent commentators with me today, Dr. Mirvat Alasnag and Dr. Peter Block, both significant experts in all of these areas. And I just want to say that from an ACC perspective and TCT's perspective, I think given the challenges that everybody has been dealing with, I think ACC and TCT now and all these major societies have done a really excellent job within the constraints of the problems of moving ahead and presenting science. And I just want to congratulate all of those. And so with that background, I think TCT has given us a lot to talk about. We'll highlight a few things. And I think I'll start today with I was struck by the fact that there were at least 4 trials at TCT that really related to identifying high-risk lesions that weren't necessarily flow-limiting lesions, particularly in the unstable ACS syndromes. And we can't go through all of the studies, and they're limited by the fact that most of them are just identifying the lesions and not showing the impact of intervention. There is one that looks at this at some detail, and that's the Prospect Absorb, which is a randomized trial of interventional treatment of vulnerable plaques. And Peter, maybe you could give me just a quick bite of your thoughts about that trial and how it may make a difference.
Yeah, I think Prospect Absorb, George, is fascinating. And it's also sort of a deja vu all over again, as Yogi Berra said, because many years ago, we looked at, or there were some trials that looked at the whole issue of thinking about treating not the plaque that caused the problem. Those were non-STEMI trials. Prospect Absorb is a STEMI trial, and then they looked at other arteries and said, well, okay, let's see whether or not there are vulnerable plaques, and then randomized treated them. So it is a randomized trial, one of the few at TCT which was set up that way. The short version of Prospect Absorb was that they treated with a BVS. So it was a first generation BVS, not a great, wonderful kind of tool to use, but nonetheless, at the end of their outcomes, the treated high lipid-laden lesion had a larger lumen, and there were some, not powered, but some indication that in fact, treating those made a difference in hard outcomes. Now, as I said, it's not powered. We need a big randomized trial, but I wonder if this is not a peek into the future, George. I would love to hear Mirvat's thoughts on this as well, but think about all of those long lipid-laden plaques that we deal with and throw out that are 40 and 50% lesions. Maybe we should start treating them. But then again, we've learned from ischemia that treating a big bad lesion is not necessarily going to be a good outcome compared to medical therapy. How we do this, but I think it opens the door to a lot of interesting questions, and I look forward to seeing a randomized trial which will come out of this.
All right, some thoughts?
Well, I think, just to echo what Peter said, is that it is an interesting concept that we've all been addressing. One is to address the vulnerable plaque, and one is to address the vulnerable patient. One thing we need to understand is that ischemia, we cannot equate it with future events necessarily. And, vulnerable plaque in these studies suggests that they can detect future events. Perhaps our role is going to be more preventive here and, statin therapy, perhaps PCSK9s, etc. I'm not sure replacing a vulnerable plaque with another issue, which is a stent and dual antiplatelet, is at this point in time the right strategy. We don't have randomized data to suggest that.
Right, but it is intriguing, and this has been, particularly in the ACS population, a kind of a nagging thought along the way that maybe some of these other plaques, that multiple plaques are turned on at the same time, and maybe this makes a difference. Well, this was fun. I think it's interesting. Let's move on and talk a little bit about lithotripsy, the Disrupt Coronary Artery Disease III trial. Looked at the safety and efficacy of intravascular lithotripsy. Peter, you have any comments?
All right. Well, this is the Disrupt trial, the coronary lithotripsy trial. We finally have a coronary balloon that actually can disrupt calcification within the coronary circulation, small enough to do that. Fascinating trial. There's no reason that it should not work. And we know in the periphery that lithotripsy is a very valuable adjunct to, for example, TAVR. I'm sure that Mirvat has used it, and I'd be interested to hear what her thoughts are about the peripheral. I mean, if you can't get a big TAVR catheter up from the leg, you just blast the calcium in the iliacs and off you go. It makes a big difference, and it will be the same, I'm sure, for the coronaries. The issue here is, from a practical point of view, you still have to pass a balloon through the lesion. And if the balloon won't go through, then you can't do it. That is different, of course, than rotablation, which is over a wire. And so I think this is going to be a toy, another tool that we can put up on the shelf and use. I think it will work, and it may be a lot safer than rotablation, particularly in areas that have bends in them or are particularly prone to perforation with rotablation. Mirvat, have you used this, or what do you think about this?
Yes, we have used it in the coronaries as well, and it's surprising that the crossability of this balloon is actually pretty good. In the trial presented, it was over 95% deliverability of this balloon. And more recently, we're reading some case reports about combination therapies where it's lithotripsy with rotablation, for example, where one is not adequate. Again, these are just reports, case reports. We don't have large data sets to actually examine which patients will require combination therapy. At the end of the day, what we do want is to debulk the lesion to allow delivery of the stent and adequate expansion of the stent, because that will ultimately determine, failure of the stent.
Yeah. Yeah, I sort of think that the niche is going to be the lesion that you can cross with the balloon, but it's heavily calcified. Well, we haven't been getting good results necessarily on those. And this may be a kind of safe way to address that, where we've sometimes ducked doing rotablator because of concerns about risk and so forth. So that's my hope. But I think you experts have some good thoughts about it. I'm going to move on now. We're trying to make this quick and informational. Mirvat, I'd like to see what your thoughts are. There were two trials presented on cerebral protection during TAVR at TCT, the Reflect 2, and then the STS ACC TVT Registry. Both of these showed safety, but neither showed definitive efficacy. Where are we now with that? How about giving us a quickie?
After over the last 2 years approximately, the use of cerebral embolic protection devices has been increasing gradually. So probably in the 2019, we're looking at around 25% to 28% of hospitals within the United States using embolic protection. But there's significant variability between the different centers, and the use of embolic protection devices, as you said, had been safe. But in terms of the pre-specified primary endpoint in the STS registry, there was no significant reduction in the in-hospital or 30-day stroke rates. Similarly, with the Reflect 2 that looked at the TriGuard III embolic protection device, comparing it to the historic TAVR data. And what they found is safety, maybe perhaps an increase in bleeds that was related more to the TAVR procedure itself. But there was no significant or clinically relevant reduction in hospital and 30-day strokes. Now, they did do a post hoc analysis where they did diffusion weighted MRIs and showed that the TriGuard arm had a reduction in the ischemia lesions, but we need randomized data. We need large randomized data sets that actually select patients appropriately that are high risk for stroke, AF patients, patients that are evaluated by cardiac CT to show atheroma and so on in the aortic arch. And then looking at both in-hospital and 30-day stroke rates would be ideal.
Yeah, to reflect too, one of the issues might be a little refinement of being able to position the catheter better where it's more stable long term. So I think there's some hope. I would admit I was on the first FDA or the FDA panel that reviewed this data, and I think we really struggled there because there was even less data and it was really hard to get handle. And I think we came to the conclusion that, you know, it seemed safe and might work, and we're sort of still at that point, but I think that's kind of the answer, don't you? And do you think you're going to see a little more use now that there's more safety data now?
I do think we will be seeing more use, particularly as more devices are coming up. So the TriGuard, the Sentinel device, and so on. But you know, as you mentioned, we are interested now in large randomized data to really show if the modest reduction in stroke that was detected in the STS registry is really because of the embolic protection devices and not other confounders.
Peter, any thoughts?
Yeah, you know, I just was sitting here listening. It strikes me that we may be short-sighted about this. One of the issues here is we know that stuff goes north, right? And when stuff goes north, if it doesn't cause a stroke, we sit back and say, well, okay, what's the sense of using it? But the question is, I wonder whether long-term these don't make a difference. And it will be very interesting. I just thought of a trial. Maybe we should look at 10 years after TAVR to see how many of these patients who had embolic protection are actually better compared to people who did not, simply in terms of their cerebral capacity and so forth, without having these multiple little hits.
Yes.
You know, I don't know the answer to that, but it's interesting. It just makes so much sense, and yet we can't prove that it makes a difference. And it just seems silly somehow, but sure enough, the data just don't come together for us yet. We need a big randomized trial.
Yep,
Well,
I think that's true.
Also, I'm sorry, perhaps they're also just looking at a certain definition of stroke. And I agree with you, Peter, that perhaps, you know, if we're looking at neurocognitive dysfunction, which is a lot more subtle clinically, and so maybe there, if we start adding these, we will see a more significant reduction in stroke if we include that in the definition.
Yeah, good thought. I like that. I like that thought because I think you know, it took us a long time, those of us that were poking catheters across aortic stenosis for years, to realize that we were putting little chunks of calcium up and it might have some impact. So I think that's important. Let's do one more, and this one kind of comes down to more everyday sort of things, and I'll ask both of you to weigh in on it. And that was a trial that was done with a patient-level reanalysis, if you will, of combining multiple trials, large trials that were randomized, looking at Bivalirudin versus heparin in patients with ACS, either in STEMI or STEMI. And it showed a relative benefit, particularly in terms of reducing adverse outcomes in the patients with STEMI myocardial infarction, and particularly if they got persistent high dose treatment after the procedure to cut down on stent thrombosis. But at the end of the 30 days, there was less, very clearly less bleeding. And so what are your thoughts? What do you use? There are a lot of practical issues about cost and so forth. So some thoughts about that one, because I think that's an everyday issue that every lab faces. Mirvat?
Yeah, so looking at the data that was presented, it seems that the Bivalirudin infusion afterwards is what really drove the reduction in events. We did see an increase in access and non-access, but you know, non-access site bleeding in the heparin arm, suggesting that perhaps you know, the Bivalirudin is safer in this high-risk patients, both STEMI and non-STEMI subgroups. it would be interesting to kind of reevaluate this study in patients who did not receive any GP2B3A inhibitors. And I wonder if the results would be any different in terms of bleeding, at least.
Good point. Peter?
Well, we all use one or the other or both, or sometimes neither, or sometimes, it's really strange how you choose. I used a lot of Bivalirudin, particularly because I loved it, simply because I could rely on it. And I think that's an important part of the practical use of Bival. The other question about this trial is how much of this is really due to access sites versus non-access site bleeding and so forth. We know heparin makes you bleed. I mean, so does Bival, but heparin seems to make you bleed a little bit more. I'm not quite sure what I learned from this trial, honestly, in terms of the practical use of one versus the other. But I think that Bival in this trial has been shown in some instances, and I know, George, you want to say something about this at the end, in some instances will be very useful and probably will be better than heparin. So there is something to be learned from this.
Yeah, Mirvat, you're welcome to step in, but I just guess I would make the following two observations. One is, although there's been lots of emphasis on access site as a way of affecting bleeding risk, and I think that's real, I think the interesting thing here is there was a difference for non-access site bleeding, which is a message. The second one is, and probably most important, is if you're going to do it, if you're going to use Bivalirudin, what I learned from this trial is you clearly want to do the high dose post-treatment to get the best results. Thoughts?
I agree with you. I know there's a lot of data from, radial studies like the Matrix and so on, suggesting that radial access is safer than femoral, and hence, in terms of bleeding. And so when we're using more aggressive antiplatelet regimens, heparin, et cetera, then perhaps the safety endpoint for something like this trial, is driven by the access site. But as you elegantly mentioned, it's actually, there is a signal in non-access site bleeding that we have to pay attention to.
All right. Well, I think this has been a really fun, interesting session. I think it reflects the diversity of information that was presented at TCT, and hopefully we've touched on some important concepts that will affect everybody's treatment in whatever they're doing. So thank you both, Peter and Mirvat, for your contributions, and hopefully we can do this again sometime. Thank you very much. This is Dr. George Vetrovec for ACC.org, summarizing on results of TCT. Thank you very much.